Thank you very much, and thank you to Francois and to the Garch team for inviting me. It's a real pleasure to be here among so many old friends and to have such a terrific meeting, particularly making new contacts among orthopedic surgeons, and this whole concept of bringing PMR and orthopedics together for this purpose is, I think, an excellent one, and I'm very honored to be here. So I'm going to talk about a study that we did some little while ago, but I think the reasons for talking about it today is that everyone needs to be reminded of the importance of dealing with spastic deformities early on following very severe brain injuries. And this is a concept that we brought together in Stoke-on-Trent and have maintained over the years in order to prevent deformities, contractures around the foot and ankle in patients who have severe brain injuries. Now, in fact, actually, when you think about spasticity and how it generates and how it is formed, this is perhaps not true spasticity. This is what I would call acute muscle shortening, which very readily leads to contracture formation. And we know that it hinders and delays successful rehabilitation because patients come into the rehab unit with contracted lower limbs, lower legs in particular, and upper limbs as well, but I'm going to concentrate on the lower limb. And it just delays the whole process of the rehabilitation. It has an adverse effect on outcomes, and more importantly, very often these patients require surgery when good prevention would have obviated the need for that. So it is important that we have, and you have, I'm going to show you, this is the typical feature that you see, the light perhaps doesn't show very well, but patients come with equinovarus deformities. They're already contracted, and the foot is very often flexed in the mid-tarsus. The toes may be flexed as well, but more importantly, it's the lower leg at the ankle that is relevant. So these patients are in the intensive care unit, and we recognize that the patients were just being left there. And if our neurosurgeon colleagues were involved in the management of the brain injury in these desperately ill patients, they would put them in nice furry boots to stop the feet going down. And you could put your hand underneath the heel because everyone thought that the process had been dealt with adequately. And there was a lack of understanding among the acute care staff, particularly those in the intensive care unit, about the importance of stopping this contracture developing. They were more interested in the major problems the patient had of the brain, cranial hypertension, of the brain injury itself, of cardiorespiratory complications, long bone fractures and the like. So therefore, these patients would spend quite a longer while than necessary in the rehabilitation unit. So we devised a study to look at preventing the deformity and seeing how we could reduce the number of complications and whether or not we would have better outcomes. And we also wanted to identify the place of botulinum toxin very early on in the brain injury rehabilitation process. And by very early on, within days or weeks of the event. Does everyone understand me? Je parle français, mais c'est meilleur en anglais. Donc, okay. So we had three groups of patients. We would have patients who would have standard treatment with physical therapy and mobilization. And then with the second group of patients, we put them into a combi cast caster, which had a back slab followed by a Scotch cast rotation cast. And then we would inject saline into the gastrocnemius and soleus muscles. And then a third group of patients, we put them in the same combi cast plaster and then injected botulinum toxin into those gastrocnemius and soleus muscles. And this is the combi cast, which we, as I said, had a back slab. We had a univalve, so we split the cast in the middle, and we wrapped it so that when the patient started to develop wasting of the muscles, as we would expect, we could tighten the cast, and we could actually also take it off for therapy, and also inspect the skin, because obviously most of these patients were unconscious, and therefore we needed to know whether we were causing any harm to the patients. And that, from a safety point of view, was a very useful thing to do. So we had a prospective, double-blind, randomized controlled trial for these three parallel treatments. These are the inclusion criteria. All these patients had Glasgow coma scores of under 9, 8 and under, and they were all admitted to our hospital. So we randomized these patients, and what we did was we applied a 65 Newton force of dorsiflexing these patients, and we measured the angle of dorsiflexion, passive dorsiflexion, in these patients. And when they were, and the entry criterion was when they could no longer be dorsiflexed to 5 degrees, plus 5 degrees, they would enter the randomized part of the study. And if they were maintained their range of motion, we discarded the patient after 28 days, because we recognized that the prospect of developing a contracture at that point would actually be far, far less. And this was the definition of the loss of ankle dorsiflexion was the definition for randomization into this study, and the definition of what we call acute muscle shortening for these patients. So we also measured the modified Ashworth score and also the Glasgow outcome scale score for the patient. And we measured both the angle of dorsiflexion every day for these patients. So we had 235 patients, but only 35 patients of this group entered the randomized part of the study, which identifies that this is not a big problem, except that within a year you have 35 patients who actually will develop contractures very, very rapidly and require a lot of treatment in a rehabilitation service. So these are the patients that we saw, male, with a mean age, and each one of those patients entered into the study developed what we call severe spasticity within 10 days of the injury. And so that highlights the rapidity of the onset of this particular problem. And I think you will all have seen these patients in your clinical practice who develop these equine various deformities very, very quickly after their brain injuries. So these were the characteristics of the patients in the various groups, the bars between the randomized patients, and they were well matched within each group. And we measured, let's say, the Ashworth scores, Glasgow coma scores, and the GOS, the Glasgow outcome scale. So this was in fact the results from group 1, the patients who were a control group. And one of the things that we noted during the study was that these patients, as I said, were very ill. And so they would develop intracranial hypertension, they would develop infections, and therefore their tone varied. There's a great variance of their tone throughout the study. Because we followed these patients up for 3 months. They were placed in casts for 1 month and then followed up for 3 months. So we found a difference in the range of motion between the patients who were cast versus the patients in the control group. We found also then we looked at the multiple comparison tests looking at the area under the curve and found a significant difference between the group who had the botulinum toxin into their muscles versus those who had just saline and cast. We also noted that if a patient developed a plantar flexion deformity, in other words, a contracture of 10 degrees or more, they were then transferred into the Botox group, and they had Botox following that. But I won't talk about those quite so much. So we saw patients who had safety problems, and safety was not an issue. We had only one DVT in the patients, and that was actually in the control group who were not cast. And the botulinum toxin was very well tolerated, and we did not have one single adverse event in these patients. And they, as I said, they were all desperately ill with many other medical and surgical complications. So we were very satisfied with the safety of botulinum toxin. Each of these patients in the randomized control group group was admitted to the study within 10 days of their injury. So we were talking about the patients at a very early stage following their event. So what do we find? We found that this was good, reliable data on patients who had spasticity as we had defined it in following severe brain injury. Many of these patients had diffuse axonal injuries, in fact, quite a significant proportion. We also saw that having good casting and good skills of our therapists in casting was a very important factor to prevent complications to the skin, to the tissues of the lower legs. And obviously, we recognized that, in fact, that if you measure range of motion at regular intervals, then you can prevent these contractures. And when you put patients into their casts, you can then leave them there for 8 hours a day and then apply therapy thereafter to mobilize the patients. We also recognize that this active intervention with casting and botulinum toxin, or even just casting, was important very, very early on. And therefore, we should train train staff rather, to have these casting skills to protect patients. And as I said earlier, botulinum toxin was safe in this group of patients, and this is the first time that it had been shown to be safe in a very early group of patients. Not one single adverse event from the botulinum toxin itself. So who needed botulinum toxin? So what we do is we ask our staff in the intensive care unit to measure the ability of the patient to dorsiflex. We have a little machine where we can apply a 65 Newton force, and we have daily measurements of all our patients in the intensive care unit. And once patients are recognized, if you have a patient who has a Glasgow coma score on emission of 6 or under, if you have patients who develop forelimb spasticity within 5 to 7 days of the event, then these patients will, and those particularly who have diffuse axonal injuries, these patients will require botulinum toxin. So those are the groups. So anyone who has a GCS of under 8 who is losing range of motion gets a cast. Now, this is our standard practice. If they have these other factors, they get a cast and botulinum toxin into the gastrocnemius muscles. And it is safe. And we have also completed a follow-up at 1 year, which I won't talk about today from a time point of view, but we have shown that actually patients do better from a cognitive point of view because they have an ability to mobilize more early in their rehabilitation process. If you can imagine someone with an equinovarus deformity, you cannot sit them or stand them, you cannot sit them in a wheelchair, so all they do is they look at the ceiling and don't get stimulated. So it is a useful and very easy thing to do. Telling the intensive care staff is something we have to do on a rolling program because they forget, they change, and they're busy. But they can measure these patients very, very easily. And it is intensive care nurses like measuring things. So it is something else that we ask them to do. But it means that our patients come to us in a much better state than they would otherwise. So the conclusion of this study is the active intervention with casting and botulinum toxin is better than just standard therapy to mobilize patients. It's an effective and safe treatment within 14 days, and also highlights the need for spasticity prevention or contracture prevention very, very early on in the intensive care process. We are now very fortunate, and we have that the rehabilitation program at Stoke-on-Trent manages the treatment of patients in the intensive care unit. We have an acute rehabilitation trauma unit, and we ensure that all these patients are assessed and properly seen. And with that, I would like to acknowledge my staff, my colleagues who are involved in this study, particularly our occupational therapists who had real expertise in casting, and they run courses on casting neuro casting is different from orthopedic casting, and therefore they recognize the need to protect the patients. So with that, thank you very much.